Good morning, welcome to this week's lecture. It's a pleasure to introduce Marit Kalliswaard. She's a third-year resident at our department, originally from the Netherlands, and she will be giving you an overview of her adrenal gland tumors. Enjoy.
Well, thank you. Good morning, everyone. So today we'll discuss the adrenal gland tumors. This is the agenda for today. First, I'll discuss the anatomy and function of the adrenal gland, then the tumors that can develop, which you can divide into incidentalomas and hormone-producing tumors, and the surgical techniques we use to treat these diseases. First, the anatomy of the adrenal gland. We have two, both cranially to the left and right kidney, which are located in the back of the abdomen, close to the large vessels. This is a more detailed overview of the adrenal gland. You can see that it has a capsule and then a cortex and a medulla. And here then the functional anatomy, which is divided into 4 zones. First, there's an easy way to learn what they actually produce. It's salt, sugar, and sex for the cortex. And in the medulla, the catecholamines, first the zona glomerulosa is the salt, because it produces the mineral corticoids. Then the zona fasciculata, which produces the sugar, the glucocorticoids. And the zona reticularis is referred to as sex, because it's producing the progesterone, testosterone, and estrogen. And first I have a question. Does anyone know which syndrome clinically comes when there's an excessive production of the mineral corticoids?
The Conn Syndrome?
Yes, that's correct. And for the next one, the glucocorticoids?
I think it's the Cushing syndrome.
That's also correct. Then we have in the third zone, we have actually the sex hormone producing tumors and the medulla. Does anyone know which disease can develop there when there's an excess release of catecholamines?
Pheochromocytoma?
Yes, that's also correct. So we can divide the adrenal tumors into functional and non-functional tumors. As you can see, the majority of the tumors are actually non-functional. Most of them are adenomas, benign tumors, but they can also be malignant tumors. The adrenocortical carcinoma from a smaller group will be hormone producing. Important also is to know that there are also other malignant diseases, cancers can metastasize to the adrenal gland. Most of these tumors are from the lung or the breast. So how do we actually get involved in the treatment of these tumors? Most of the time, a patient will present from another department with an adrenal incidentaloma. As you can see here on both of these pictures, they can be small, they can be big. And also, when they present like this, most of them will be adenomas, non-functional in 75%. But also here, of course, the malignant diseases should be considered as well. So then the diagnostics for the adrenal incidentalomas. So when a patient presents with that, there are 2 important things. First, can this lesion be malignant? Well, it can already give an idea about that with the CT scan, but if we're uncertain, we should do a PET-CT or an MRI. And the second thing, is it functionally active? And for that, we need to test for excessive production of adrenal hormones, which I'll discuss later. Then it's important to establish a definitive diagnosis, and there are then 3 options. First, it's a non-functioning benign lesion, can be an adenoma, can be a lipoma, and no further investigation is required. These tumors can also, or lesions can also be clinically relevant because of their hormone production, or potentially malignant. Then surgery is required, or it's an indeterminate mass and additional investigations are required, or one can choose to operate on them and see at histology afterwards, or follow up and decide to surgery later. Then the surgical treatment, or the indications for surgery, as I said, are hormonal activity or the risk of a malignancy, and radiological features are important here, like an inhomogeneous lesion, but size is actually one of the main concerns. And if a tumor or a lesion is more than 4 centimeters in diameter, surgery should be considered. As you can see in this table from a study in 2006, the likelihood of a lesion being malignant exponentially increases with the size of the lesion. And it's actually said that if a lesion is less than 4 centimeters in diameter, there's only a 2% risk of malignancy, compared to when it's more than 6 centimeters, there's a 1/4 patients will actually have a malignant lesion. So if it's decided not to operate on these patients, which follow-up is indicated? Well, if the lesion is less than 4 centimeters and it's clearly benign on imaging, no follow-up is required. If it's an indeterminate mass, there should be an additional follow-up with a CT or MRI in 6 to 12 months. If it's then growing, surgery should be considered. Then, when the hormonal workup was negative in the initial workup, there's no workup required in follow-up. One exception is a silent Cushing syndrome, where the patient will not have symptoms of a Cushing's syndrome, but actually have slightly elevated levels, and this should be follow-up every year. So then we go to the hormone-producing tumors. First, we have the Conn Syndrome, the primary hyperaldosteronism. As you can see here, the RAS system is involved, where the adrenal gland produces the aldosterone, and there will be a negative feedback into the RAS system, and also lower renin levels. This is the normal system. Then, in case of a Conn syndrome, and there's an excessive release of aldosterone in the blood circulation, this will lead to a renal sodium reabsorption, intravascular volume expansion, and also hyperfiltration of the kidneys. This leads to symptoms of hypertension, hypokalemia, and a headache, and most is seen in young patients. This actually shows that the renin levels go down in these patients, and therefore there's an elevated aldosterone to renin ratio, which is an important diagnostic tool for this disease. And the second diagnostic tool is the oral salt loading test. Then, if there is a primary biochemically proven Conn syndrome, there should be an adrenal CT scan should be performed, and also adrenal venous sampling if the site of the lesion is not certain yet. Then it can be divided into two groups. You can have the unilateral Conn syndrome, which most of the time is an adenoma or hyperplasia, and a surgery should be considered. If it's bilateral, most of the time a spironolactome will be started, because if you take out both adrenal glands, you will, of course, induce adrenal insufficiency, or also known as the Addison disease. We would like to avoid that. Then the second syndrome is a Cushing syndrome, is the hypercortisolism, which can also be divided in different groups. First is what we see a lot as well, is the exogenous Cushing syndrome, which is if we prescribe glucocorticoids, for example, for autoimmune diseases. Then the endogenous forms. First we have the pituitary Cushing's, which is actually the classic Cushing's disease, or the morbus Cushing, which is a pituitary tumor that excretes ACTH. Then the adrenal Cushing, which we'll discuss here further, is the adrenal gland tumors, which are most of the time adenomas, but can also be a hyperplasia or a malignant tumor. And then the last one, which is a more rare group, is the paraneoplastic Cushing's. That's a non-pituitary tumor causing hypercortisolism due to the release of ACTH. Most of the time this will be a lung tumor, a small cell lung cancer. This is the axis of the cortisol metabolism, with the hypothalamus, pituitary, and the adrenal cortex. You can see that with the release of ACTH, the cortisol will be released from the adrenal gland, which gives then a negative feedback back to the hypothalamus. Then, in case of an Adrenal Cushing syndrome, there's an excessive release of cortisol, which will then give a negative feedback back to the hypothalamus and subsequently the pituitary, and you will have low levels of ACTH. This is also shown here in this figure. First, actually the clinical, the first diagnostic for Cushing syndrome is actually the elevated serum cortisol levels, or elevated levels in 24-hour urine. Then, to see what actually is the cause of this Cushing, you can do a high-dose dexamethasone suppression test. This will show in the adrenal Cushing's a low ACTH, and then on the left side you then come to the adrenal Cushing syndrome, and also a CT adrenal gland should be performed to see if there are any lesions in the adrenal glands. So if we have this, there are also another 3 options. In case of an adenoma, it can be unilateral or bilateral, and surgery should be performed. In case if there's a suspicion of an adrenocortical carcinoma, so malignant tumor, surgery should be considered if that is an option, or adrenolithic therapy or radiotherapy. And the third case is the hyperplasia, which can be unilateral or bilateral, and then further evaluation is required to see on which side it actually comes. Then third, we have the androgen and estrogen producing tumors. They are rare, but actually usually malignant. If there is an excessive release of androgen, a patient can develop hirsutism. Women can also have polycystic ovarian syndrome and infertility, alopecia, and in men, episodes of excessive aggression are observed as well. If there's a release of estrogen, in men there can be a feminization, also with gynecomastia, a decreased libido, and also testicular atrophy and infertility. Then we get to the medulla of the adrenal gland, and here the tumor that can develop is the pheochromocytoma. This is a tumor of the chromafin cells with the potential release of the catecholamines, or the noradrenaline and adrenaline. 90% of these tumors are from the adrenal medulla, but they can also be extra-adrenal from the sympathetic ganglia. And also 10% of these tumors are malignant, and 25% of them are hereditary. They can develop in the context of the Conn Syndrome, neurofibromatosis, or von Hippel-Lindau. These patients usually present with the symptoms of the 5 Ps, which can be high blood pressure, palpitation, perspiration, pain, and pallor. But these patients can also present actually as a medical emergency when they have a pheochromocytosis crisis, which presents with hypertension, hypothermia, encephalopathy, and also multi-organ failure. These tumors are also first tested with biochemically. The metanephrines in the plasma can be tested and then it can be confirmed in 24-hour urine. Then, if this is positive, also scan should be performed, adrenal CT or MRI. There's no certain lesion, a PET-CT should be confirmed, and then actually all patients should have a surgical removal of their adrenal gland with this pheochromocytoma because of the risk of the pheocrisis and also the risk of malignancy. Then we have the primary malignant tumor of the adrenal gland. That's the Adrenocortical carcinoma. It's a rare tumor with an incidence of 1 to 2 people per 1 million. They can be sporadic, but also hereditary in context of the Lymphadenectomy syndrome. Most of the time, these patients will present as very young children, younger than 5 years of age or between the 4th and 5th decade. These tumors can be non-producing hormones, so that they're actually silent, but actually very common. They will have a Cushing syndrome or an overproduction of both the glucocorticoids and androgens, and in children it's actually seen that there's more virilization. These tumors are also have, of course, the TNM stadium, which previously was made and developed by the Sullivan and colleagues, but there has recently been an update from the NSAT, as you can see here. These tumors are also aggressive. There's a 5-year survival of 20 to 35%. If surgery is an option, which is not in all patients, a 5-year survival is reached between 50 and 60%. Then the surgical options for the adrenal gland tumors. First, it's very important before we get to surgery is that the anesthetist and endocrinologist get involved, especially in the hormone-producing tumors. First, for the Conn syndrome, it's important that there's a full cardiovascular workup because the hypertension can also cause cardiovascular disease. There should be a normalization of the blood potassium concentration and also good control of the blood pressure. In Cushing syndrome, it's important that steroids are given, especially postoperatively, as otherwise they can develop an Edison crisis. And in the pheochromocytoma, it's very important that the patients are monitored intraoperative very closely, because only if you can touch the tumor, there can already be a release of these noradrenalines and adrenalines. And the volume expansion should also be given afterwards. The surgical techniques, we have the classic open technique, and then afterwards laparoscopic approach was developed, and over the last years we also have the Retroperitoneoscopic approach and the robot-assisted adrenalectomy. Over the years, several studies have been done. This is a first comparative review and meta-analysis in 2006 in the British Journal of Surgery, where 20 studies were compared with more than 2,000 patients. However, there were no randomized controlled trials in this review. But here the author suggests that the laparoscopic adrenalectomy is a safe approach. It gives less blood loss, less morbidity, and a short hospital stay compared to the open technique. There's no difference in mortality, so it should be the gold standard. So that was in 2004. And then also this National Institute of Health statement suggested that a laparoscopic approach should be standard, but in case of a large tumor or also risk of malignancy, an open approach should be considered. Then this is a meta-analysis from 2017, and here there are 26 studies have been analyzed with 1,700 patients. Most of these studies were randomized controlled trials or clinical controlled trials, so to better make a comparison. Here there was a comparison of the open method or minimally invasive, which can be the laparoscopic approach, the robot-assisted approach, or the retroperitoneoscopic approach. And actually the authors suggest they don't have a preference for any type of minimally invasive approach, but they say it is safe and it should be the first choice in uncomplicated adrenal tumors. Then to further discuss the retroperitoneoscopic approach has potential advantages because there's no opening of the peritoneum, so there will be no peritoneal seeding in case there's a malignant tumor. And a bilateral access can be obtained without repositioning the patient. However, there are also disadvantages potentially because there's a reverse anatomy, so you have to adapt to that, and there's also a size limitation. For large tumors it will not be that easy to resect them. Then at last, specifically for the adrenocortical carcinoma, so the malignant tumors, should a lymphadenectomy be performed? This is from a German group where they looked at if in patients who underwent resection for the carcinoma, in case if there was a lymphadenectomy performed, actually had better outcomes with a reduced risk of recurrence and also disease-related death. And the same group, the German ACC registry, had a further look on their outcomes. And in 65 patients, they published this paper this year, and they looked at the recurrence of these malignant tumors in the lymph nodes, and they saw that the recurrence is actually quite extensive. So they suggest that each patient should have an extensive lymphadenectomy if possible to prevent recurrence of the carcinoma. So in conclusion, tumors of the adrenal glands, most of them to us will present as an incidentaloma. Mostly it will not be of clinical relevance, but also it can be hormone active tumors that show a different clinical picture. You should always have that in mind. And the indications to operate are, of course, hormone production, but also suspicion of a malignancy, so a size more of 4 centimeters or other radiological features. The minimally invasive approach is standard, but there's still a role for the open approach in case of malignant tumors or large tumors. Thank you very much for your attention.
Thank you, Marit. That was a very nice overview of the adrenal gland tumors. Are there any questions?
Yes, Marit, thank you very much for this wonderful talk. I really enjoyed it. Thank you. I have a question in the surgical technique. Is there still a role of partial adrenalectomy in 2019? And if yes, in which indications would you do that?
So there is, for tumors that are really have a very low risk of malignancy, for instance, for the patients that have a Conn Syndrome, that have a very demarcated lesion that you can see, it's allowed to do a partial adrenalectomy because the malignancy there is less than 1%. However, the risk is always that if you don't see it very well, if it's more centrally, it will be difficult to not injure the lesion, and then you'll have higher risk of recurrence. So it's always a bit of a there still is a role, and it's allowed to do that in that situation. But for most other tumors, you will do a total or bilateral even. Yeah. And just one thing to add, because it's very important, the perioperative endocrinologists that look after the patients, for the pheochromocytoma, the alpha blockade has to be done preoperatively. It's not just at the day of surgery, but it's done 7 days before, and the beta blockade is not always given, but it's given if the patient is tachycardic or has palpitations. Yeah.
I have a question. If you ask the interventional radiologists, they say they can treat them too. So, are there any studies about interventional ablation methods?
Yes, there is actually a study. It's radiofrequency ablation versus surgery, but this was from an interventionologist. The surgeon was a side, and they showed equal success rates for Conn syndrome. That was the small rates, and that was a first study. We need to see if that remains. Yeah.
It was an excellent talk. But what we did not hear is that also we can have metastasis to the adrenal glands, and this can also be an indication for surgery or radiotherapy or ablation by the interventional radiologist.
You're absolutely right. We left out that topic because it's already quite a big field, but that's obviously very true. And there, if you have metastasis, it very much depends on what the primary tumor is, if you will do surgery or not. And of course, there are other treatments as well. And also for the malignant tumors, there's also, of course, the role of chemotherapy, which we didn't mention here.
Beautiful presentation. Thank you very much. My question is, it's still a rare procedure. It's a rare indication. So can you comment on the learning curve? How many operations do you need to do to be able to do a minimally invasive adrenalectomy on your own? And also, is there a referral pattern, or are there any movements to centralize these operations in Switzerland?
So the learning curve, I'm sure it exists, but it depends. If you do a laparoscopic adrenalectomy and you're a surgeon that does laparoscopic procedures on a regular basis, I think the learning curve is not that big. For easy cases. If you then do the retroperitoneoscopic approach, I think it takes a little longer because it's just an anatomy that abdominal surgeons are not used to. It's certainly a disease that needs to be performed in the future in centers because, as you said, the numbers are not that big. We're trying to aim there, and the first thing is to actually assess the quality. So we're doing registries in Switzerland that are supposed to look at the quality. That's the first step to see that the quality is probably better in centers that have higher numbers, and then to centralize. Yeah.
Perhaps I have a question. What is easier, left or right adrenalectomy from the technical point of view?
I think the right side is a little easier, but sometimes it can be very difficult because the issue is the vein is actually the issue there. And if you have a very big tumor, which we also do laparoscopically, we have to admit we don't just go for open surgery. If we see a nice demarcation, that can be quite a critical situation there. But otherwise, generally for normal sized tumors, I would say that the right side is easier. Okay, so if there's no more questions, thank you very much.